Hello, this is your brain on drugs, and this is the punk rock psychiatrist. That was Responsibility by MXPX. I thought, it was a song about how it's a song about how they're, making the transition into adulthood, and they don't quite want that responsibility yet. And I thought, it kind of has a relation to ADHD, where you don't want to think about things, you don't want to be responsible, you don't want to, or you have difficulty responsible, you have difficulty with organization. Perhaps if ADHD were in check, it would be easier to take on that responsibility. So it was a song that resonated with me. That they're around my age, and I was coming of age around the time that song came out, and I was in college, and I really kind of related to that. So today we're going to start with methylphenidate. I'm probably going to do 3 shows on the methylphenidates. There's quite a few of them. Might squeeze them into 2. We'll kind of see how things go. But, we went over all of the amphetamine products over the last 2 ADHD episodes. And before that, I kind of described how amphetamines work versus how methylphenidate works. So if you want to kind of hear that, that's an episode before that. But since we're talking about methylphenidate and it's been a while, I just want to remind you kind of how methylphenidate works in contrast to the amphetamines. All right, so whereas they are both norepinephrine dopamine reuptake inhibitors. All right, however, amphetamines have all those other mechanisms. Um, they they touch the NDRI, the norepinephrine dopamine reuptake, differently. They lean a little bit more in the dopamine direction than methylphenidate does. They're stronger. They interact with VMAT2. They interact with TAR1, and they filter across membranes. They have all sorts of different mechanisms that make them work a little bit differently. Whereas the methylphenidate medications are just simply norepinephrine dopamine reuptake inhibitors. And similarly, they have levo and dex enantiomers, so left-handed and right-handed enantiomers, and um, those work differently, of course. So the mixed dopamine and levo, which is methylphenidate, interacts at DAT at 121 Ki value, and at net, that's norepinephrine at 788. So lower numbers are stronger, so stronger at the dopamine. And then the pure DEX does 206 on the dopamine reuptake pump and 161 on norepinephrine. And the DEX product is Focalin. All right. And then there's a Focalin XR as well. So those would be your differences there. So the mixed product does a bit more dopamine. I think I said norepinephrine does a bit more dopamine. Um, Many of you may be thinking, isn't bupropion a norepinephrine dopamine reuptake inhibitor? Yes, of course it is. But I mean, there's actually some others that are not approved in the United States. I think there's one in development right now, or there's one that's used for narcolepsy that's a NDRI, but it is not approved for anything outside of narcolepsy yet. I think it's solriamfetol. Don't quote me on that. Um, but that one is actually doing some testing to see if it could be used for mental health stuff. So they're just like we have different SSRIs and SNRIs, you have different NDRIs, and methylphenidate works differently than bupropion. In fact, it may work as an inverse agonist on the dopamine reuptake pump versus only antagonism. And I think when I explained this before, I didn't do it justice. Just to go through kind of agonism, partial agonism, antagonism, inverse agonism, so we can be clear on what that is. You have a receptor, and its agonist is kind of what would normally interact with it. So for the dopamine reuptake pump, it would be dopamine. All right, so dopamine would be the agonist. And then you can make a drug that's also an agonist. So basically, if something's an agonist, it does the same thing as the native compound that's in your body would do anyway. Okay. A partial agonism basically means that it doesn't agonize it as much, right? So it's kind of like, I think of it as a keyhole, and like an agonist, it's the perfect key that fits in the hole, turns it, everything works perfectly. A partial agonist is kind of like you're picking the lock, you get it open, but it's not as quick, it's not as smooth. You don't quite get it open as well as you wanted to. So, but you do get it open a little bit. And so a partial agonist can actually have antagonism effects against the native agonist, right? So, whereas dopamine would be the agonist that's in there, if your partial agonist drug binds onto the receptor more strongly than dopamine does, it can block dopamine from getting on and doing its full agonism. And then it only does its partial agonism. Now, if it works as a full agonist, it's going to do the same thing as dopamine anyway. And so it doesn't have that kind of antagonism effect. Even though it is antagonizing against dopamine, it's working just the same. And then you've got an antagonist, which I think about as kind of like putting gum in the keyhole, right? Like now we can't get the key into the hole, right? We can't get it in there. We can't even try and turn the door, right? So that's basically we're sticking onto the receptor with our drug so that the dopamine in this case can't do anything, right? It's kind of has the same effect as the partial agonist, but it also doesn't turn the key at all, right? It doesn't open the lock at all. It just gets in there and stops the native substance from getting on there. And then we get to the inverse agonist. And the keyhole analogy doesn't fit quite as well with this. What you have to kind of think of is the receptor, so this dopamine pump has intrinsic function. So it actually works without the dopamine. So it kind of does its function without dopamine being there, but dopamine enhances it and makes it work better, right? So when you antagonize dopamine, the receptor still functions. So it has this intrinsic activity. So so basically intrinsic to itself, it has activity on its own without needing the chemical to bind to it. What an inverse agonist does is it lowers that intrinsic activity, right? So we're not just gumming up the hole so that the agonist can't get in there and turn it on. We're actually like, it would almost be like taking a hammer to the lock, and just destroying it to where it was just completely non-functional in a way, right? So say that the receptor has some activity even when it's antagonized, but when you inverse agonize it, you kind of warp it to where it doesn't even work as well as it does normally. All right. And of course, you can have different degrees of inverse agonism, different degrees of partial agonism. This is your intrinsic activity. It can go up and down. All right. Hopefully that makes sense. And so the idea here is that methylphenidate may be an inverse agonist of the dopamine reuptake pump versus only an antagonist for bupropion, meaning that this is the pump that would suck dopamine back up into the cell so that it's not out there to do what we want it to do. Well, bupropion might block that, but methylphenidate completely shuts the receptor down. And so we're getting essentially even less dopamine being sucked up into the cell. So hopefully that makes sense. And it kind of helps you understand how why this medication is so much more effective than bupropion. That may be one reason why. I'm sure there are other reasons. The thing is, it works immediately. Bupropion really doesn't. It just doesn't work as well. And then, of course, bupropion also doesn't affect the dopamine reuptake and the norepinephrine pumps to this. It doesn't have the same Ki values on those. So methylphenidate is just, it has a stronger bond to the pump, and then also blocks it even more. So that's why it works so much better. All right. So, but we do use bupropion sometimes to help with this. I don't think it's a great choice if you're treating like real ADHD. If you've got someone with ADHD kind of like stuff going on, plus they've got some depression, anxiety, and that's like kind of the primary, you may get some bonus improved concentration. But if someone's got like ADHD as their primary problem, bupropion's probably not going to do the job. I've seen it help enough. It helps a little bit, but it's really, kind of fourth, fifth line product. All right. So this effect increases alertness, reduce fatigue, improves attention. Um, Initially, it was used for barbiturate-induced coma. We're talking about methylphenidate here. Narcolepsy and depression. Later, it was used to treat memory deficits in the elderly, and beginning in the 1960s, it began use for ADHD in children. And we're talking about it second because amphetamines came out first. All right, so methylphenidate. What is it approved for? So adults and kids, it's approved for all the same stuff. There is a product, Datrana, at least Datrana is not approved for after 12 years old, but that is just one individual methylphenidate product. Methylphenidate in general is approved for adults and children. Not that you couldn't use it if you wanted to, but they're approved for ADHD, and that's methylphenidate. And we've also got, remember how we had 4 amphetamines? We had mixed amphetamine salts, we had dextroamphetamine, we have lisdexamphetamine, and we've got amphetamine base. We've got 3 products on the methylphenidate side. We've got methylphenidate, we've got dexmethylphenidate, the pure right-handed enantiomer, and then we've got a new product. This is one of our newest products, serdexmethylphenidate, and it's a little bit like lisdexamphetamine. And so that'll be the last one we talk about because it's the last one to come out. So we have 3 products. They're all approved in adults and children for ADHD. For narcolepsy, only methylphenidate is approved. Remember, it helps those with narcolepsy stay awake, stimulates them. That's kind of the idea there, because narcolepsy, their whole sleep-wake thing, they go in and out of sleep random times, right? All right, next, off-label. There's some off-label uses for methylphenidate in adults, fatigue, severe fatigue in those with cancer-related or palliative care settings. So fatigue related to cancer and palliative care. Major depressive disorder in the medically ill, but I've used it not in the medically ill for major depressive. Usually it's like an add-on to one of our regular depression medications. Palliative care. So this is MDD in medically ill, palliative care, terminal illness, or elderly patients, but I've used it in regular adults as well. We have the same black box warning, the abuse, misuse, and addiction. So we talked about that when we talked about amphetamines. They changed that a few years ago, and they took off some of the cardiovascular stuff, but that actually was never listed for methylphenidate. The cardiovascular risk was only listed for the amphetamine products. They took it off for that, and they standardized it across all of the stimulants. All right. So we're going to go through a few of these medications today, and we're going to start with the first one, and that is methylphenidate. Brand name Ritalin, right? It was named after the discoverer's wife, Rita, right? Because he was hoping it was helping with like blood pressure and stuff like that, raised blood pressure. I don't know, but she and he both were experimenting on it. This is interesting. There's a lot of folks now that are kind of experimenting on themselves. Brian Johnson is one of them. I'm actually kind of interested in this guy. I know a lot of doctors don't like it because they think, oh, he's experimenting on himself. It's N of 1 experiments and stuff like that, and these are nonsense. And there's a few people doing this. There's a husband-wife team. I listened to a talk with her recently, but it's not proof that something works. But if you do something on yourself and something is found, that could be grounds to study it further. And that's how we got a lot of important products. That's how we got Ritalin. It was he experimented on himself and on his wife, and now we have this product because of that. There was the treatment for H. pylori for ulcers, stomach ulcers. No one believed this guy that that this was the problem. So he like infected himself with H. pylori, gave himself ulcers, cured himself of H. pylori and cured himself of the ulcers, and said, "Look, this does work. I did it on myself." So I mean, I wouldn't recommend this, but um, I think whenever we kind of criticize those type of things, we have to look at our history and see that this is something that was done. And if you want to do something with your body, you can do something with your body. You know what I mean? So let's see. Ritalin, 1955. It's dosed 5 milligrams twice a day to 20 milligrams 3 times a day. Off label, so that's a total dose of 60 milligrams. Off label, you can go up to 100. I would not do that very often, but it can be done. And as you note, this is a dosed 2 to 3 times a day product. This is a immediate release. So also, how I was telling you about the kind of equivalent doses between the different amphetamine products. We'll do that for methylphenidate as well, but it's for the most part a lot simpler. Um, Almost every different medication of amphetamines had a different kind of equivalency. With methylphenidate, the products are a little bit more standardized. Um, but in general, methylphenidate is half as potent as the amphetamines, or mixed amphetamine salts anyway, not pure amphetamine. So mixed amphetamine salts, which is like the 75 dextro to 25 levo combination. It's the one that we use the most often. So that's the one I kind of um, am showing you the equivalent. So 40 milligrams of mixed amphetamine salt, which is Adderall, is equivalent to 80 milligrams of methylphenidate. So you can kind of see if somebody's on a 20 milligrams 3 times a day, that's 60 milligrams. That's equivalent to about 30 milligrams of mixed amphetamine salts. So that can help you with, if you're changing someone from one med to another, kind of understanding what doses we're dealing with, right? So we do need higher doses of methylphenidate, um, because I mean, that's 30. We usually go to 40. We can go to 40 if we want to with that one. So you could certainly go to 80 and even 100 with methylphenidate. All right. So what formulations do we have? We have a lot of options here. We have tablets. So the tablet form is Ritalin, right? So Ritalin is the tablet form only, but there is a generic tablet. And then we have a generic liquid. The liquid we're going to talk about in a second, brand name is Methylin, all right? Methylin oral solution. And then there's a chewable that is generic. And there used to be a Methylin CT chewable tablet, which is no longer available, which was the branded product. Methylin oral solution and Ritalin still exist, but the generics are just as good. They're much cheaper. And so we have generics of all three formulations. Onset of action, pretty standard, 20 to 60 minutes. Time to peak, pretty standard for an immediate, 1 to 4 hours. Duration, 3 to 4 hours. This is an immediate release product. You can see why we might need to dose it 2 to 3 times a day. Can you split it? As the case with immediate release products, yes. This is approved for 6 and up. So what you'll notice is the amphetamine products that are immediate release are approved for 3 and up. And even the long acting ones, but there's that warning to say, don't give it's actually not approved for 3 and up for the long acting amphetamines. It's 6 and up. But the FDA put out that warning in July of this year, 2025, saying, this causes weight problems and so forth, and be careful with this, and, probably don't do it. Methylphenidate is actually not approved for those under the age of 6 at all. But it can be used off label. It's actually a less potent product. So I would think that if you're going to go under 6, the amphetamines are the ones that are approved. So you're probably going to do that first. But if they don't work out, methylphenidate is a less potent product with less adverse effects. I would think that you could probably get away with that. And that is done. All right. And is this generic? Yes, I already mentioned that. All right. So this is an easy one. The next one is the methylphenidate liquid, which the brand name is Methylin oral solution. Came out in 2002. its dosing is actually a little bit different. It says 5 to 30 twice a day. It's a liquid. We talked about liquids before with the amphetamine products, that you have that option of adjusting them in smaller gradients by the milliliter. So one advantage of a liquid is that if you can't swallow pills, even if you could crush it and put, I mean, you can crush the other one anyway, but perhaps, I mean, honestly, I'd rather crush it and put it into something than drink a liquid, because often, I mean, liquid medications just don't taste that good, and often there's like more volume of it. So if it were me, I'd rather just have the pill, crush it, and put it in my pudding or applesauce or whatever, right? That's what we typically do for kids. But the liquid, eh, you can swallow it, but they taste bad, don't they? I mean, I've never had this one in particular, but I'm just thinking about all the liquid medicines I took when I was a kid and how disgusting they were. It says this is grape flavored. It's clear, so it's clear, but it should be purple, right? No, it's grape flavored. It's clear. I don't know if it's the gross grape flavor that like cough medicines are, but take that for whatever it's worth. But the big advantage is that you don't have to give specifically 10 and 20 milligrams. You could easily give 12 or 17. Like you can fine tune it more to like what the patient actually needs. Now, typically for most patients, you're not going to have to do that. But you also have that advantage of changing it for different days. Like, oh, I can give this, maybe on this day there's greater need, and so you take a higher dose, and so forth. All right. Um, can you split it? Of course, because it's a liquid, 6 and up, and it's generic. All right. So that's the liquid at 2002 for Methylin oral solution. Next, we have methylphenidate, the chewable version. Now, this was formerly known as Methylin CT, CT standing for chewable tablet. Um, it says dosed 5 milligrams twice a day to 20 milligrams 3 times a day. This was discontinued. Normally, I have the date that these were discontinued. I should have put that in here. This came out in 2003. It was probably discontinued around 10 years ago. A lot of these products were discontinued kind of in the 2014 to 17 range. Um, I have that on some of these other products that were discontinued. But the generic's still available. Same onset of action, time to peak duration. Split it, yes, because it's chewable, 6 and up, generic, right? This is all the same as our first methylphenidate immediate release product. It's just chewable. And a chewable may be, I tended to prefer a chewable over a liquid when I was a kid. So this gives you another option. All right. So those are our immediate release methylphenidates. And I don't believe we have any. We have Focalin, which is dexmethylphenidate, which is an immediate release. But most of the rest of these, if not all, I believe all the rest of the ones I'm going to talk about are extended release. All right. So they're all known as methylphenidate ER. All right. So when you see the generic name, they're methylphenidate ER, but there are like 10 of them. And so you have to know which methylphenidate ER you are dealing with. So this first chart I've actually brought up here compares Ritalin LA. These are all the branded names. It compares Ritalin LA with Metadate CD, with Concerta, with Ritalin SR. Now, Metadate CD is no longer available, but its generic is. Ritalin SR also no longer available, and it doesn't have any equivalents that are still available. But this chart, you can kind of see that Concerta has the smoothest. They all kind of have the same area under the curve, meaning that they're delivering the same amount of drug in a similar period of time. But Concerta has the smoothest curve, right? We're going to talk about, when we get to Concerta, we'll talk about that. Ritalin LA, its curve is the spikiest. So it kind of spikes on, drops, and then spikes real high, and then drops. And so that's typically not appreciated by patients, to kind of have a quick onset and then like a withdrawal and then another quick onset. We want those smoother curves. So Ritalin LA is probably not um, the best option for most people because of that. And then you've got Metadate CD, which is actually similar to Ritalin LA, but has a different way that it's comes out, and we'll talk about that. It's much smoother, okay? And then Ritalin SR, it kind of came on a bit slower, and it has a shorter length of time by which it acts. But if you look at the slides I have, you can see kind of the curves. They're all kind of superimposed on each other, and you can see, oh wow, the Concerta curve looks the best. So let's talk about each of these medications. So methylphenidate ER, I'm going to first bring up Ritalin SR. That was a sustained release. That's what SR stands for, product, and it is no longer available. So this was the first one that came out, but there's a reason why I'm still going to mention it. Came out in 1982. So this was the first extended release product that came out. It was discontinued in the US in 2014, and then I have that it was discontinued in 2020 and 2022, and that one of those is Canada and one's New Zealand. So it lasted a bit longer in some other countries, but it's pretty much completely gone now as of 3 years ago. It was dosed 10 to 60 milligrams just once, so similar dosing, but just once a day to the IR product. It was available as a tablet, 20 to 60 minutes onset of action, 1.3 hours to 8.2 hours time to peak. So a little bit longer time to peak, especially with that second peak. That was not a great aspect of this medication. Duration of action 6 to 8 hours, so like kind of a medium acting. So this one did not last very long, and it tends not to get people all the way through the days. So if you're maybe a younger child, like 6 or 7, maybe it was enough, but for most people it was not enough. I'm guessing that the reason why it was discontinued is because it doesn't have the smooth curve, and it just didn't act long enough. It's like, well, now all these other products, they act between 8 and 16 hours, and this one was only like 6 to 8 hours. So really wasn't giving us enough coverage. Um, and also the other thing was you were not able to split it. Some of the other products you can split, but this one was a no. All right. 6 and up were the age. And what made this tablet kind of unique was it was a continuous release tablet. So the difference, oh, I made a mistake when I was telling you about those curves. Um, the smoothest curve actually was this SR formulation and the Metadate. It was when you look at the Concerta, it was the one that it kind of starts slow and then ramps up. So it's not as smooth maybe as we would want it to be, but it doesn't hit as hard. So the Concerta kind of hits a little bit softer, and then it has kind of a steady increase, and then it bumps up and has a smooth curve. So Concerta kind of might hit a little bit slower and then has a smoother finish. But this SR product and Metadate CD, according to this graph that I'm looking at, have the smoothest curve. So sorry, forget what I said before that was contrary to that. So this is a continuous release tablet. So essentially, it's not like a lot of these ER products are biphasic and triphasic, meaning that the drug is released twice or 3 times. Like kind of like how we talked about with the amphetamines. You release an IR part of the med, and then there's like a delay, and then you release another IR essentially, and that is the ER. But essentially, it's like another coating that needs to be eaten through, and then that second dose of IRs is released. And sometimes, in the case of Concerta, a third dose might be released. So you have either 2 doses are released or 3. My Deus was another one that was like kind of a triple. So some of them are more in the triphasic sphere, right? This one was just a continuous release product. So it just kind of slowly released itself continuously. So it's a continuous release. Sometimes products that are continuous release will be labeled as CR. For whatever reason, they named this one SR sustained release. I'm not sure that sustained release and continuous release are different from each other. They're pretty close, right? But what I have noted here is there was a less predictable release due to the wax matrix. So kind of um, the tablets had a wax matrix on them, and that was how it did its gradual release. But the kind of dissolution of that wax matrix was not necessarily even. So it did not have a consistent release. And so even though that curve that I showed you or talked about before, and you could look at it on your own, looks really smooth. I mean, that's a curve that the drug company essentially, like, that's their perfect model. But when you're actually taking it kind of in real life, you are getting kind of this less predictable release. All right. Now, the other thing is, um, and this is the first time I brought this concept up of branded generics, right? So this product, I mean, it's pretty old, 1982. It went generic a long time ago. Um, so you can have a generic, and then you can have what's called a branded generic. And a branded generic is essentially like the drug is generic, and I'm a company that wants to make this. And instead of just producing a generic product that I call methylphenidate ER, I slap my name on it and I call it Metadate or Methylin, right? So Methylin, which makes the oral solution of the immediate release, they made a version called Methylin ER that was a version of Ritalin SR in generic form. So I'm not sure that like a branded generic is all that different from a regular generic. I think the difference there kind of is regular generics, you don't really know who's making it. It could be made by anyone. It may not be consistent. A lot of people don't like taking generic because they find that they think that they don't work as well. Part of that is like a nocebo effect where like they just kind of believe it's not working as well, even though it probably is doing exactly the same thing. Um, and part of it is that the generic may not be engineered exactly like the branded product and may not have its ingredients as consistently measured. It just may not be under as tight of control. And most of the time, that's not the case, and it's perfectly fine. Sometimes there are inconsistencies, and with Concerta, that is the case, and we'll talk about that issue when we get to Concerta. So, when a company is going to make a branded generic, basically they're saying we're allowed to make a generic, but we're still going to have a brand name, which kind of allows them to charge a little bit more money and then also kind of say, hey, we have a more consistent product. And so it's typically going to be cheaper than the original brand, but it's going to be more expensive than the full generic. Okay. And then but it's maybe going to be a little bit more reliable and more equivalent to the original branded product. So basically, you're getting a cheaper version of the better product. That's kind of the idea behind it. So we had two for Ritalin SR. We had Metadate ER, which was from 1988 to 2011, and it basically had the same wax matrix. And then we had Methylin ER, 2000 to 2016. It was discontinued, and it used a hydrophilic polymer tablet, which was thought to maybe be more continuous. So where I said that wax matrix, which is what Ritalin and Metadate used, Methylin used a hydrophilic polymer. So a polymer is basically like a really long chain molecule that's made up of a bunch of subunits that are kind of the same, and you just kind of repeat them over and over. So they're like monomers. Poly means many, so it's like all these little monomers that are like chained together. So basically, just like it's just a chemistry thing that the chemical engineers came up with that is the substance used in this particular um, delivery device capsule. And it was thought to be more continuous in release. But at the same time, you really need to know it. This product's not available anymore. You can't get Methylin ER. And in fact, you can't get a generic of any of this. So the regular generic of Ritalin SR also doesn't is it's not made anymore. But however, and this is why you may be thinking, why have I been talking about Ritalin SR, Meta ER, Methylin ER, and all this crap? Well, one, there's those of you like me that have been around long enough to remember when these products existed and you used them, and you may not have been aware that they weren't available anymore. And the other point is to kind of note, hey, if this is something that someone's asking for, there's a reason why you can't find it. And also, if you do find it, don't use it, because there's no authorized generics at all of this product. It's just like, it's not a thing. And so there may be unauthorized generics floating around out there, but they're not to be used, because they're not to be trusted, because there's no authorized product out there. All right. So that's the main reason why I wanted to talk about this, kind of from a historical standpoint, and also from a, have some caution. If you do see it, don't use it. All right. The next product is once again called methylphenidate ER, and it's Ritalin LA. LA stands for, can you guess? Long acting. All right. So this is similar to like an ER or an XR. It kind of has the similar. It has the first, where you've got 50% of the immediate release speeds, and then you've got 50% delayed release speeds. It's kind of like an Adderall XR, where it's similar. It's a 50-50 product, right? You release some beads, and then a little bit later you release some more. All right. This came out in 2002. 20 to 60 milligrams, off label up to 100. It's a capsule. Onset of action 20 to 60 minutes. Time to peak 1 to 3 hours for the first dose, 5 to 11 for the second dose. For adults, the second dose may be a little bit different, 4.3 hours to 6.5 hours, so maybe a little bit quicker. It lasts, this was the longest acting product in 2002 when it came out. It beat the SR product at 8 to 10 hours. Another advantage. Now, remember, we couldn't sprinkle the SR product, and that's because it was like kind of that waxy thing. So you couldn't really split that. This one, because it's beads, we can open it. And remember, it's a capsule, so we can open it and sprinkle it. And of course, you could sprinkle half of it. You might just have to kind of like eye it out. You can't crush it or chew it, because then that would, make everything release at the same time, and then it wouldn't last long enough. And you would get too high of a dose up front. Age 6 and up, which is pretty much across the board for most of the methylphenidate products. As I said, it's a 50-50 IR and a delayed release system. It also had a branded generic, which was Metadate. Metadate is pretty much gone. Metadate had made CD and ER, and now it's just gone. Methylin made ER, but it also makes the oral solution, what is still available. So Metadate CD came out in 2001. It's kind of interesting. That was like a year earlier. No, but it's kind of a similar product, but it's actually different than LA. Maybe I should have made a separate slide for it. I didn't realize here it came out a year earlier, 2001, but it was discontinued in 2017. However, there are generics of it available, even though Ritalin LA, the branded product, if you wanted to spend the extra money, which you shouldn't, is still available, but a generic of Ritalin LA is also available, and a generic of Metadate CD is also available. And the CD stands for controlled delivery. Okay, so you're kind of, so that these are making just some sense for you, I guess. But it's not a 50-50. It's a 30 IR and 70 delayed release speeds. And so it gives a much smoother curve. And there is a generic of it available. So I think if you're going to use a generic of this product, use the Metadate CD version versus the Ritalin LA version. You're going to get a smoother uptake there. All right. So I've got the curves here of Ritalin LA versus 2 doses of Ritalin. And it shows, bigger spikes if you're dosing the immediate release twice versus the LA product, and that's typically the case. They have kind of matching spikes for their first peak, and then the peak for the second peak is higher for if you took 2 IR products. We generally do not want to use the IR, and I've kind of talked about this before. If you've got a really young kid, they may only need an IR in 1 dose. They may not need a second dose. You also might want to use the IR when you're starting the medication, especially on a child, to kind of see how many doses they need and when they need to be dosed and what the dose they need is. And then if they need the 2 doses, consider switching them over to a long-acting product. Concerta is probably going to be too long for a lot of young kids, We haven't talked about Concerta yet, but it lasts longer. And so the generic of Metadate CD is going to have that 8 to 10 hour. Since we don't have the option of the 6 to 8 hour SR product anymore, if you need a longer acting product and you're trying to avoid the 2 IR doses so you can have a smoother onset and a smoother off titration, because the faster something pop goes on, the more you're going to have like side effects when it's onset, and the more you're going to spike blood pressure and things like that. And the faster it drops, the faster they're going to get withdrawal symptoms, which is like irritability and discomfort and things like that. That's why we want that smooth curve. We're going to talk all about that once we get finished talking about medications. I'll talk about all these different aspects like that and how to mediate them. And of course, just like the Adderall products, you can use IR on the end of a extended release product to extend its duration of action if this biphasic is not enough. We do have some longer acting products now, but they might tend to be more expensive. So if they're not approved by the insurer that you're using, you do have that option of adding that IR. All right. So those are the same uses for the IR. Methylphenidate are the same as the ones we had for the amphetamines. All right. So that is the Methylphenidate ER Ritalin LA Metadate CD product. All right. And just to kind of talk about how the difference in the way their beads are, it's a little bit different. So Ritalin LA has 50/50 beads. So the immediate release beads are released right away. And then its extended release beads have a polymer layer, and then the drug layer, and then an inactive core. And so that polymer layer gets eaten through, and then the drug comes out. With the Metadate CD, you've got difference. 30% of it is a protective membrane, followed by drug, followed by core, and that is the one that's released right away. And then the 70% continuous release, you have a protective coating, and then a protective control membrane, and then a protective coating, and then the drug, and then the core. And so that membrane actually it's just kind of separating the layers. It gets eaten through pretty fast, but it's just kind of keeping the drug from the protective coating separate. All right. And like on the immediate release bead, it's just kind of protecting the drug from, dissolving on your tongue or something. Right. So, or from like inside the pill. But basically, because of the way this is engineered, it's actually a little bit better than the LA. And then I think we're probably going to wrap up here with Concerta. And there's a lot to kind of talk about with this one. This is an interesting product. So it's also known as Methylphenidate ER. And so if you may be thinking, well, how do I even find these generic products when I'm ordering them? Unfortunately, every one of these systems kind of labels these differently. You may see Methylin ER and then in parentheses Concerta equivalent, or in parentheses Concerta, but it's not actually Concerta, right? If you want to order Concerta, it's going to say Concerta. If you want the generic, it's going to say Methylphenidate ER. Maybe in parentheses it says Concerta. Maybe in parentheses it says Concerta equivalent. Maybe it says OSM, which is osmotic. And we're going to talk about why that would be called. So, and then in most cases, if you order the branded product, it's just going to get changed to the generic. So if you order the branded product, the pharmacy is going to switch it on you. If there's a generic available, they're probably just going to change it. And so you have to put in a specific approval to get the branded product, right? Basically, you have to put in for like a non-formulary request of, no, I want the branded product. We've tried the unbranded product. The patient didn't react well with it. They took the branded product. It does work. And then you have to wait for the pharmacy to approve it. And the insurance, of course, are they going to pay for the branded product or not? You want to make sure they approve it. And then you might be able to get the branded product. So that's the thing to be aware of when you're ordering these. You can just go ahead and order Concerta, and then they're going to give them the generic. All right. But like every system is different. And then, I mean, all you need is to give a patient a product, and then they go to the pharmacy to pick it up, and they're like, that'll be $200, please, because these branded products cost like $15 to $30 a pill. It's insane. That's how much like branded Concerta costs. It's like $15 for like the smaller doses and $30 a pill for the larger doses. It's crazy. And so what? That's not covered by their insurance. They go to the pharmacy, it's like $500, and they're like, "What?" Usually it's like 30. It's like, yeah, well, that's because this is Concerta and not the other one. And then they're gonna be like, "I'm not picking this up," and then they're calling you back to say, "Hey, what happened here?" And you'll be like, "Oh, I got to put this in again." All right, so no more. I think is are all these type of issues more confusing than with ADHD drugs because there's just so many darn many of them. So Concerta came out in the year 2000. It's kind of interesting that the long-acting product actually came out after it, and it's not as good, but it is shorter acting, and so that might be beneficial, especially for younger patients. Concerta is dosed a little weird, so it's 18 to 72 milligrams. Um, the 18 milligram dose is equivalent to 15 milligrams of regular methylphenidate. And it's actually, I mean, if you want to get technical, equivalent to 3 separate doses of 5 milligrams because it gives 3 doses. It gives 5 milligrams, it gives another 5 milligrams, and it gives another 5 milligrams if you give them the 18. All right. So I think because the pill has got some kind of interesting construction to it, and we're going to talk about that. And probably that's why the pill weighs a little bit more, why it's 18 milligrams versus 15. So it's got a little bit more weight to it because there's a little bit more going on inside the pill. And this is also why it's more expensive because it's pretty interesting construction that they did on the pill. Um, the normal dosing range is 18 to 72 in the morning. Off label, you can go up to 108 because remember, that would be like 100 or something like that. Max dose is 54 for those age 6 to 12. So for the younger kids, they don't want you to go up to 72. The way this is formulated, so this is not a tablet. This is not a capsule. This is an Oros capsule. And Oros is a patented term, and it is an acronym that stands for Osmotic Release Oral System. All right, and I'm going to tell you why that's important after we go through the rest of the details. Onset of action, same 20 to 60 milligrams. Time to peak, 1 hour for the first dose, 6 to 10 for the continuous dose that comes later. Durations, as I said, a bit longer, 10 to 12 hours. For adults, a little bit usually on the lower side, maybe even less than that. For the smaller the kid, maybe even more than that. But the average would be probably 10 to 12 hours. Can you split it? No, and that's because this Oros capsule is very complicated in the way that it's constructed. If you split it, it would completely destroy it. Approved for kids 6 and up to adults, and it consists of really 2 components: an initial release component, which is 22% of the dose, and then a continuous release component, which is 78% of the dose. And there are generics. A few years ago, it was found that these generics were inferior. And, I had always been told generics are not inferior, generics are not inferior. And it was like, no, these Concerta generics, they're bad. Okay. And a lot of those quality control issues were solved. But there are still, but generics could be made by anyone. You don't know which generic the pharmacy you're using is carrying. They could be carrying this brand that you don't even know the name of the brand. It's some like brand of generic pills, right? It may be different from a different pharmacy. So you're picking it up from different places, different states, different, CVS versus, Walgreens or different stores at Rite Aids, and they're using different brand, generic brands. It was just a lot of inconsistency because of how cool this pill is constructed, and they just were not using the technology that Concerta used to construct their pills, and so you were seeing a lot of inconsistencies in doses and in smoothness and all this other stuff. And so what I've been told is Alza, I think Alza actually makes Concerta, but they also they also make generics of their own pill, which is weird, if that is the case. But that seemed to be to me what it was. But if you see Alza, Alza written on the pill, that is a generic you can trust. And so if you're getting a generic, There may be other ones you can trust, but like look and see what's on there and look it up and see if this is, especially if it's not working well for you. See what's going on here and go to your doctor and be like, hey, this is some messed up generic you gave me. And there actually is a branded generic. They gave it kind of a weird name, Relexi, and they spelled it weird, RELEXXII. I'm not sure why they've come up with this spelling. I don't know if this XXII has something to do with the Roman numeral for 12. I'm not really sure. It came out in 2024, and the things that makes Relexi different from Concerta is supposedly it might be a little bit cheaper, but when I looked at prices, it's pretty close to the same price. Um, it does come in some different doses. So whereas methylphenidate comes in an 18, a 36, a 54, and a 72, this one only comes in 40. This one also comes in 45 and 63. So it's got some intermediate doses. And since you can't split the pill, if 54 was too much and 36 wasn't enough, you've got the 45 and then you've got the 63. So that may be, and the generic also comes in these doses. But what's interesting, the generic of the 45 and the 63 milligram doses was significantly more expensive than the generic pill size of the standard Concerta sizes. You see how confusing this is? This is why you're listening to this podcast, because you're like out there in the muck doing the work. You don't have time to dig into this kind of crap. They didn't teach you about this stuff in residency. And it's like, what? I got to worry about different pill sizes, cost different amounts, and different insurances and pharmacies and different generic manufacturers. And I need to worry about the quality in this pill, but probably not other pills. And this is stuff that you may not have learned. It's something you have to kind of figure out on your own. You're like in the muck. You don't have time for that, right? So hopefully you're listening to me in the car and you're getting it there. Another thing is, whereas Concerta used the patented Oros osmotic release oral system technology, Relexi uses something, their patented technology, and because the Oros is patented, no one else can use it. Relexi uses Osmodex, is what they call theirs, which it is different. So the Concerta pill has 3 compartments inside the pill, and Relexi has 2 compartments. And now you're probably wondering, what is Oros? What is Osmodex? What are these compartments? Why is this pill so special? Why is the quality on the generics? What the heck does this pill do? This is a special pill. This is one of the most interesting pills I've ever seen. All right, so without further ado, let's talk about how it works. So this is neat here. So the coating on the outside of the pill is actually drug. So there is a capsule that is inside. So there's a capsule, but the capsule is coated with drug. So when you take the medication, the outside of the pill comes off first, and that's your first dose of med. So that's your immediate release. It's the coating on top of the pill, which is kind of neat. I've never actually handled one of these, so like I don't know if you like could see the difference between the drug overcoat and the the rate control membrane that's underneath it, but that is how it's constructed. So that's how you get dose number 1. Now there are 3, as I said, there are 3 compartments inside the pill. It's a tri-layer, right? There is a laser drilled hole on one end of the pill, and you can actually see this if you look close. So there's a laser drilled hole. And then behind that laser drilled hole is drug compartment number 1. In the middle of the pill, behind that, is drug compartment number 2. And then at the bottom of the pill is a push compartment. So what happens is, this is called an osmotic release, right? So water through osmosis comes through the rate controlled membrane into the push compartment. And when the water gets into the drug compartment as well, but when the water gets into that push compartment, it causes that push compartment to expand and force the drug out that tiny little laser drilled hole. And then drug compartment 1 shoots out the hole, and then drug compartment 2 shoots out the hole. I don't know why you need 2 compartments, because that push compartment is just pushing everything up. And when you look at the graph, you see a pretty smooth, after that initial dose that's from the coating, you see a pretty smooth curve. So and that may be why Reluxi was kind of like, we don't need the 2 drug compartments. The we have 2 compartments in our pill, 1 push compartment, 1 drug compartment, whereas Concerta has 2 drug compartments for a total of 3 compartments. And so Reluxi and Concerta have been kind of verified to be equivalent in how they work, but they are slightly different because of the difference in drug compartments. And so that's how it works. It gets forced out that laser hole. And so that's why you get such a smooth release. The first release is less smooth, and it's like like a less intense amount of drug. But then you basically have drugs shooting out that laser hole, um, continuously from compartment 1, compartment 2, or whatever. And so that's how Concerta works, and it's pretty neat. And then I've got a graph here that kind of overlays how Concerta works versus taking 18 milligrams of Concerta versus taking 5 milligrams 3 times a day of methylphenidate. And when you look at that methylphenidate 5 milligrams, you've got spike, drop, spike, drop, spike, drop. And then for Concerta, you've got kind of spike, level, and then curve up and over and down. So much smoother. All right. So just wanted to break in, and I did some research after I recorded this episode just to like kind of double check what I said about those authorized generics. That's what they're called, of the Concerta product. And so basically, the technology that's used in Concerta, that Oros patented technology, is only used by the company that makes Concerta. I believe it's Janssen. And so that's why the generics of this product are not as good, because they don't use that same technology. And it's that technology that actually makes the Concerta work as well and as smoothly as it does. So, like, the generics will have like beads or something else. It doesn't have that push through the laser hole technology thing. And so, essentially, before the patent ran out, the company that made the drug made what's called an authorized generic. So basically, they made their own generic, which it seems kind of unusual. It's like, well, who would buy the branded product now if you can get a generic from the company who actually produces it? So basically, it is exactly the same thing. Well, they stopped about 2 years ago, late 2023, early 2024. The one I said that had like the Alza written on it. So unfortunately, that doesn't exist. And so there's just Concerta. If you write for Concerta, they're going to give you the generic, and the generic unfortunately isn't the same thing. You have to write some, if you're the prescriber, you need to write something on there that indicates that you want them to get the branded product, and then they may run into insurance issues with that. Now, the Reluxi product, or Relexi, however you say it, is equivalent. It's the only other thing that's actually equivalent to Concerta. And I've looked at prices on these, and they're fairly similar. And unfortunately, they're pretty expensive. So you're looking at somewhere between $15 to $30 a pill, depending on the size. So the smaller pills go for like 15, and the larger ones go for like 25 to 30, unfortunately. And so even if you were to like double up on the smaller pills, it would end up costing about the same price. And then Relexi, they do about the same price. I did read that there may be options for coupons for the Relexi product. I don't know if those are still available and how long will they be available, but it said that whereas you'd be paying like over $400 a month for Concerta, you might be paying, even more than that for Relexi, but with these coupons could be as low as 80 a month. Um, but that would probably be mostly out of pocket. And so that's kind of a big hindrance if you have the insurance problems, and then you're being given these generics, which are essentially not equivalent, which is unfortunate because generics are supposed to be equivalent. Well, the drug inside is, but the drug inside is just methylphenidate, which is in, all these products. Basically, all the products we're talking about on these like 3 episodes are pretty much all methylphenidate. And so, I mean, the the fact that we have all these different products, one part of the reason is the delivery system. It's the pill itself. It's the technology of the pill that makes it last longer, and how it makes it last longer, and how it's smoother. And we've got one that has a delayed onset, and it's all about like this construction of this pill. And so most of the ones we're going to talk about later are not even off patent yet. And so you may be wondering to yourself, well, what the heck do I do if this is not affordable for my patient, but this is really the best thing for them? And it's like, well, you could give them, say, like the Metadate CD generic product, or you could give them the short acting and give them 2 or 3 doses, but then you're going to get those like spikes where it goes up and down really fast, and it's not going to have that smooth curve. The alternative would be to go with like an Adderall XR type of product, which is equivalent to the Adderall XR branded product. So, like a mixed amphetamine salt extended release would be equivalent to like an Adderall XR. It would have a similar duration of action, and it's going to have similar efficacy. But say the patient has tried the amphetamine product and they didn't tolerate, and the methylphenidate product works better for them. Well, then you're kind of stuck. Maybe you try and use this coupon situation with the Relexi, see if that works out, but they still probably have to pay something out of pocket for it. Their insurance may not cover any of it. And you're just going to have to look and see what alternatives there are to Concerta. And we're going to talk about those products. And like I said, when I get through all the methylphenidate and amphetamine products, I'm going to do a price breakdown. But at the same time, like, that's not necessarily what an individual patient is going to pay. It's going to depend on their insurance. It's going to depend on um, probably some other factors. If they, the diagnosis, you got to make sure that that matches up. And their age may have a factor in there, and um, just their insurance, their copay, what their deductible is, all those sorts of factors. And then, like, were they able to get these coupons or not? And so it's tricky. And then, different insurance companies may pay different amounts, and some may cover drugs and some may not. But it'll at least give you kind of an idea what the retail value for these are. So if you're looking for, like, okay, what might be an alternative, we'll just kind of do a comparison at the end. I don't know how helpful it'll be, but we'll see how that goes. But yeah, I just wanted to kind of throw that in there. Um, the Concerta product, you probably need to have the actual thing, and hopefully their insurance covers it. But yeah, I mean, over 400, and you might be, if they're on a higher dose like an adult would be, you're looking at like over $800 a month, which is kind of insane, to be honest with you. We're talking like 10 grand a year for this medication. I mean, that's just like not a very good option for, you know, the vast number of people that need these medications. That's a really expensive cost. So uh, that's just, I wanted to break in and give you that update. And the thing is, who knows, there might be a generic available at some point in the future. These things change, and it's like really hard to keep up to date with this. And if I find out that there is like a good branded product, branded generic product, or authorized generic or whatever that comes out, I'll put out maybe a 5-minute episode just to say, hey, just so you know, this is out there. So back to the show. And so that takes us through Concerta. And so before we finish up, I'll just mention that, you may be wondering how would I dose these. For kids, I would always start at the lowest initial dose for kids, but like with adults, out of all these products we've kind of talked about up to this point, I only use Concerta, right? Like, especially for adults. I'm not needing. I mean, I might use the short acting, but I mean, Concerta is already a triple acting. Do we need to add something on top of it? Maybe. Um, some of the products we haven't talked about yet do last longer, so like that might be a possibility. The SR not available anymore, and the LACD, like, it just doesn't last long enough, especially for adults. And honestly, for adults, I tend to start them on 36 milligrams. I usually will not mess with the 18 milligrams for adults. Um, if I think that they're going to be sensitive or they've been sensitive in the past, I might give them 18s. And in fact, something I often do is I tend to use the amphetamines a lot more often in adults, as I've mentioned before. Um, but of course, I've used both. And the way that I've done methylphenidate is I'll often give somebody 18s, and I will say, you can take one the first week, two the second week, three the third week, four the four the next week. It's actually a pretty cool med to be able to titrate. And of course, I tell them, don't keep increasing it. If you get to 36 and you're like, hey, this is great, stay there, right? If it's not working and you feel like you need a higher dose, after another week, go up to the 54. Could they go up faster? Yeah, they could go up faster. But I usually see patients back in about, 4 weeks anyway. And so this kind of gives um, them kind of time. And it also makes it easy for them to remember. Oh, I started on a Tuesday. I'm going to increase the dose on a Tuesday. It just makes it easy for them rather than saying like 3 to 7 days or something. And then they're like, well, when did I do it? Are they keeping track of this? Or are they using a calendar? It's easier for them to just remember they started on Tuesday. And so up on Tuesday, up on Tuesday, up on Tuesday, right? And then of course they will take it however the heck they feel like taking it. But they're only going to be given enough pills to take it this way. So if they up their dose faster, they're going to run out. All right. So that's often the way I'll dose this. And honestly, I often see my ADHD patients back in 2 weeks because these drugs work so quickly compared to all the other psychiatric medications. If I've got time in my schedule, I might like to see them back sooner so I can get them fixed sooner and so I can have them on their way with refills and not needing to follow up as often, right? So either way, but that is an easy thing to do. And I might even say, you could start with one if you want, or you could start with two. If you want to start with two, go ahead. And if you need more, you can go up to three after a week. Or I'll say, you could use just the one for a couple days, and then if you want to go up to that second one sooner, go for it. But then I'd probably space the third and the fourth one out a little bit longer. And so, it you got to personalize it. And that's the thing. This is why AI cannot do my job as well as I can. I know it might be able to do other people's jobs as well as they can or better, but it can't do my job as well as I do because I personalize my treatment to every patient. I take details that are going on with each individual patient. I don't dose everything exactly the same with every patient. I don't give everyone exactly the same med. I don't give them in the same ways at the same times, etc. I listen to their whole story. It might be, oh, this for you it might be better to take it in the morning. For you it might be better to take this at night. For you it might be better to split this in half and take it twice a day. For you it might be better to do this. Or I might say you have all these options. You do whatever you feel works. If it doesn't work in the morning, move it to night. If it feels too strong, split it. And so I take what my patients are telling me and I adjust accordingly. Okay, that's how I do business. Um, and so I can't tell you straight up how I would do it for every patient. I will tell you how I do it on average and how I might make slight adjustments depending on how I'm kind of feeling and like what details I'm getting from that patient. All right, because and you may be thinking, oh, this isn't important, just do whatever, just follow the drug information sheet. The thing is, this could be the difference between this patient taking this medication and not taking it. If you start them on too much, they may be like, oh, this was awful, I don't want to continue this. And if you don't give them instructions on how to increase it, they may think it doesn't work. If you don't tell them how long it's going to take to work, it may not. They may quit it before they get to that point. If they have a side effect that may only last 1 or 2 days, something like trazodone, where you're going to get this grogginess, but a lot of people after they take it a few days, it goes away. Not everyone, but like if you don't explain this, you come back and they're not on the med anymore. right? So, and I still make these mistakes. It's hard to hit every point, especially if you're a little bit rushed or you didn't remember it exactly. But customizing this to the patient and kind of giving them flexibility inside of that is going to increase your success. And so that's generally how I dose Concerta. Um, and if it was a child, I would probably not start a child on this. I would probably start them on something else. And then if I noticed that like they were needing a certain length of action or a certain dose, and I thought that that would fit well with Concerta, which is like easier to take, I might switch them over to that. But for adults, I'm going to go straight to Concerta, and I'm probably not going to mess up around with any of those other ones. Now, the meds that we haven't talked about yet, there's some reasons to use those. So I always like to tell you like when I would use each med and when I wouldn't. I've kind of explained when I would use the immediate release. We've talked about that. The SR not available, so no option. And of course, we've got chewables and liquids, and we talked about why we might want to use those. And then the LA, I told you I don't really care for this product that much. A benefit of it is you can sprinkle it, so it's a longer acting product. Consider that they have to be able to swallow. If they can't swallow, Ritalin LA may be an option for you. But even better, Metadate CD, which are beads, which you can sprinkle. So using that, I don't know that I would really use the generic Ritalin LA product, but unless you could not find the generic Metadate CD product, this is a product I would use in patients that couldn't swallow, that needed a longer acting product. All right. If it's not long enough, I might add an IR onto the end. And so that's where I might use those. The Ritalin LA, I would only really, I mean, it works differently. I'm not going to say it's bad for everyone. Someone may not like the generic Metadate CD. We'll try the generic Ritalin LA. Maybe they'll prefer it more, even though, kind of logically they shouldn't. But everyone's body handles these things differently. So you never know. And so just because one thing doesn't work, if something works differently, maybe a 50-50 is what they needed and a 30-70 was not what they needed. Okay. So you have to take stuff like that into consideration. And then, like I said, with Concerta, this is my go-to methylphenidate product. The ones we haven't talked to yet, I barely use any of those. Concerta is the one I use the most because I like how long it acts. I like how smooth it is. I like that it's got some generic options. It's been around for a really long time, and it's been available to me the entire time I've been practicing. Now, are there some products we haven't talked about yet that I'm excited about that I'd like to be able to use and that I would want to use? Heck yeah. And we're going to get to that on subsequent episodes. I want to thank you for joining me today, talking about some methylphenidate and some of the methylphenidate ER products. I hope you learned some things you didn't know and that you're excited to learn about the other methylphenidate products. And I'll see you next time.